Good morning, everyone. I'm delighted to be here and to tell a little bit about our journey with DI over the last 4 years and what we've accomplished, in that space. As was mentioned, my name is Kruse. I'm the AVP for Strategic Operations and have led this effort on an operational side, but with the support of a really large clinical and analyst team that exists all in our operations. And so a lot of times you'll hear me say they did a lot of things, so sort of the shepherd in how this works. I'll be talking today a little bit, I'll give an overview quickly of Penn Medicine and who we are. I'll go through our journey over those last 4 years, and then I'll transition a little bit into some of the newer analytics that we're developing and are being supported and I think are sort of the next step in where we're looking to go with our analytics. So just a quick overview of Penn Medicine. We are both the two organizations combined that make up Penn Medicine. It's the University of Pennsylvania Health System, as well as the Perelman School of Medicine. We operate in the southeastern Pennsylvania, south half of New Jersey, and Maryland and Delaware, and we are a fully comprehensive integrated health system. We have 6 acute hospitals. We have over 200 practices around that area and go all the way a robust home care rehab facilities. In addition to that, we have over 37,000 employees. We are the largest employer in Philadelphia, and so a very big organization with a for this particular, a very high need to want data and live, everything we do is data driven, and so a huge part of how we operate. So, if I go back 4 years where we had started in this journey and a part of partnering with Dimensional Insight was we did need to develop a consistent enterprise definitions and dashboards. And like many of you that started out on your journey, whether you're past where we are or you're earlier, it wasn't for lack of data. Tons of data. If we look about it, we had tons of dashboards and reports. I mean, thousands of reports. And we both have a centralized analytics team as well as distributed analytics throughout all those different pieces of the organization. And every request, every report was another opportunity to redefine how you want to count a surgical site infection or how you want to count admissions or how you want to count length of stay. And so, you end up with data that is conflicting and just not efficient. I mean, we can't grow that way where every time a new report gets generated, that user gets to define what some of those metrics are. And it just isn't a way to go. So we set out on this path to start to develop these enterprise metrics, and we started internally first. So, part of what I'm going to tell is what we needed to make this happen and make the partnership with Dimensional Insight successful. So in 2018, we started internally. We had no data governance. We created what we've called data domain committees, and we're now at 8 of them. We started, sort of 3 and kept adding them on as we continued to develop and build out our dashboards. But, these committees are operationally led. We have both our clinical leadership in there, we have our analysts in there, and the goal was to really empower these committees to be, you guys get to define what our enterprise analytics are. I'm happy to say that in all this process, I never defined a metric, I never built a dashboard, and that was really, really important for our success. So when we charged these groups, we basically said, you guys are going to own this entire process. So there's a demand here as well, which means we need your time, we need your knowledge, we need your expertise. We're going to build this out, but we need your time for validation. And so you're going to own the metrics, you're going to define them, and then once that happens, we're going to be able there to support you, to show them really quickly in dashboards, show what they look like, so help you with the validation part. Help build out some of those views, and sort of that rapid cycle process was really, really key. Because we'd gone down this road before, and one thing we'd done without a partner like Dimensional Insight before was we got them in a room and said, you need to develop metrics. They developed it, and it sort of went into the ether. There was nothing to show them 2 weeks later, 3 weeks later when they got together back in a room. And it just doesn't work. I mean, they lose attention. They're very busy. And part of what we wanted to do to say was, for every hour you're going to put in, we're going to do 10 hours in the background, because it needs to be that cycle. And so, what is that background process? So this is exactly where Dimensional Insight comes in. So we know these committees are getting together. we're going to integrate them, but we're going to need to get that rapid cycle and get that. So if they define 10 metrics, we need to make sure that, when they meet back in a month, there's a dashboard with 10 metrics on it that they can look at, take a feel, and it's that rapid cycle that really made the difference and actually got us to where we were not able to get there before. As part of the, we developed this triad. I mean, there was no way to do this other than integrate DI into this process. And so, one thing I'd say to the group that worked with us, and Julie Lemro, you're getting another shout out. James Kirtley, you're getting a shout out in the room. Jeremy Polchak, and I'm sure I'm forgetting others. These are all people that had to sit next to our clinicians, had to sit next to our other analysts, engage, discuss, and that was critical. So we talk about this customer success factor. That was enormous for us because there's no way, you can't have a divide in there. It all has to be integrated together. And so this ability for these teams to integrate together, we really did go with a phased approach. This was the first time operationally we were telling you guys can own this stuff. Before it used to be like this was an IS process. This was now a operationally led, but they're like, well, we don't know what to do. Well, okay, the first meeting, we're going to list the first 10 metrics that you guys care about. Just give us 10. And then on the second meeting, we're going to define them. The third meeting, we're going to show you a dashboard that you're going to have them. And in some cases, you'll see where we're at now, where we're right now at 250 metrics, and they totally get it. But start with 5, start with 10, start with something that says, this is the enterprise. And because in those meetings, we have every single entity represented, when this came out of it, it was an enterprise metric that was now defined, and that can't get changed. And if you create a new report, they have to be using those metrics. And that was a huge, huge change for us. So what did that bring us in terms of our 4 years of work? We started first in quality. We did similar to the other story. We had an old system that was being deprecated. Quality needed a replacement. We started that work in June, first dashboard available in October. I mean, that short type of cycle. Ambulatory was another huge, they also had a real challenge with data access, and we started working with them. They went live in February of 19, and you can see, again, the number of metrics that have been approved there. Since then, we then looked at our hospital side. We did surgery, we did ED, we did hospital, all through 2020. And then our most recent one just got launched in January, our ICU. And so, when you add this all up together, we're talking about over 1,500 enterprise approved metrics throughout this group. I would say in total, there's probably between all those committees, about 180 people that we involved from the operational side on this process. So this was not don't send your B players. I mean, we had our chief medical officer leading the quality group. It wasn't, we needed the analysts that were involved and their time and their validation, the effort. So it was all on board. And so, from that standpoint, it has been a huge success. And also in terms of the enrollment, I mean, we developed, you can see more than 20 videos around how to use this. So we went to the YouTube channel. You want to 10 minutes. How do you find a quick metric? How do you get a trend? How do you get this by month? All the way to full-on training sessions where they were in the room for a few hours, learning how to use the system. We now have across all 6 of those about over 1,000 active users. By the way, these are our real tiles. I saw some other tiles that look a lot nicer. We're going to have to talk about the little prettier images. We have so that's on the list. But this has been from the standpoint of where we're at now, I would say if there's a foundational, sort of checkbox, I think we're there. A lot of what we have in here are our foundational views. Where we're trying to, I think, transition now is we're looking to expand the user base even larger than what we have. And what we're starting to do as we get out of it is we have 5,000 physicians. So the physicians are starting to get access and look at it, and they say, well, this is really great. You guys created these views, and I'm sure they were with the right intention, but we need these 5 data points, and they're in these 3 different dashboards and in these formats. Can we just get one page that has our 5 metrics in this graphical view that we want? And so now it becomes that, how do we rethink the way in which individual groups need to be accessing information and make it easier? We're very big on friction. one click, we look at it. I mean, you add another click, you lose 10%. You add 2 clicks, you lose 50%. It's like this has to be easy. It has to be right there. They click on it, they know what it is, they get the information. Another thing we're moving towards is user-based access, so that if you're a nurse, we hire you, you get access to all your clinical information you need, your information systems, your rooms that you're going to be seeing your patients in. You should also get access to all the analytics you need as well. And so now we're looking to automate that access point so that you don't even need to say, can you give me access? Right? You get it as part of your role. You join in, you get access, you leave the company, you lose access. And during that time, you can just automatically log in and get what you need. And that is, again, it's a friction point. Because if they look in, I got to go get a password, I got to submit a request, well, whatever, I don't need to do that. And it's just that kind of friction is what we're looking to really remove, make it as easy as possible, and really bump up the value of it. I think in the earlier presentation you heard about leveraging it. This is all built now. It's like the leverage part is really what we want. All the value is just increasing that one number where the cost side is already invested. So let's get the numerator a lot bigger when we look at an ROI. So that's where our journey is for the last 4 years, and I'm happy to go into any of these on a sidebar. I can also say, in fact, we did go into one of them. If you look at one of the user groups in 2019, Daniel Carr from our peri-op group did run through what they did for the surgery module, so it's on video on Dimensional Insights website. So if you do want to go there, it's just going to give you another view and to just get a better idea of an example of how we rolled out one of these. I'm now going to shift and just talk about a couple areas that I think are more novel, more interesting. Because we have this sort of framework in place, we now can do some advanced analytics, and it's a lot more fun, and it just shows the power of getting through and having all your metrics sitting there that you can now do a lot more with them. So one of the things that's happened in healthcare has been a change in the way in which we are looking to move around getting paid. We are, for those that are in the space or even in other industries where you've had sort of your underlying economics change, we are moving from what has been a volume-based approach to payment. You do services, you get paid, into a value approach where you now have a lot more metrics that they want to be able to track you on, and that is going to influence on the payment side. And so one of those challenges that quickly comes in is that there are a lot more metrics that we now need to be aware of, track, make sure we're doing well, and that's definitely influencing where we're going with some of our analytics. When you think about how you want to succeed in this new changing environment, you got to take your providers, your physicians, your nurses, the leadership, and educate them on how this works. You want to start getting into a lot of clinical redesign around how patients move through. A newly heart failure patient, a new stroke patient. How do they move through these care pathways and care coordination to really be efficient in the delivery and make sure that what you're delivering is high quality, high value care. And then, if you look on the last thing is, and we also need analytics. Well, it turns out that on all these areas, analytics is really, really important to this, because we used to went out and educated some of them and say, we're going to have a new program, and you're going to be responsible for these metrics. Well, they're busy. They walk out of the room, and already the metrics are out of their head. It's like, okay, well, we'll circulate out a PowerPoint. It'll show you what's in there. Well, okay, now they have a PowerPoint. That doesn't get it. Because they're still looking at it. I don't know. Are we doing well? How are we trending? You put a dashboard in front of them and said, these are the 10 metrics we're going to get rated on here. Here's your performance and trends over the last 2 years. Here's your averages. Here's how you're performing compared to your peers, and that's real. And so analytics is really key into where we need to go in order to be successful in this new environment. So I'll show one example that I'll highlight just a couple things and then show an example of what it is. One of the challenges with these programs is that if they frequently are either payer or employer-based, and they're coming up with the metrics. So here we are meeting with a physician saying, here's how we're going to grade it. They say, well, what is that metric? And other than showing them some paper definition, the answer is, well, we don't know. We don't have it. They may get it to us, and we'll show you what they say we are performing. At the same time, when we get that information, it tends to be quite dated. It's not unusual to have information given to us that is 6 months, a year after that performance period is over. And, to go into a physician to say, listen, we need to do better on this. And they look at it and they say, well, yeah, that was a year ago. Like I got patients in the room right now. Like it doesn't resonate very well when there's not the actionable piece to it. And so, part of what we're trying to do when we build these out is to, how do we overcome some of these challenges? A lot of the, when we track it, I mentioned these measures are sometimes external. We also have our own internal measures we want to match up against it. And so, we get their view. We don't always get what our internal outcomes are. And what we like to do is be able to blend them together. And finally, we've gone down this road in some cases where some of these views have been built out in either other portals or other places. I mentioned that frictionless point. I mean, no one is going to go log into another platform. We've shown it. This stuff needs to be right alongside. If they're going to go in and look at their own quality data and they're going to look at one of these value programs, it has to be in the next tab, sometimes in the same tab. So it's got to be adjacent. It is one-stop shopping. That everyone knows if you've had the challenges around user adoption in the space, it has to be easy and right next to it. So, in terms of how we're overcoming some of this, this is an example of one of the value dashboards that we have built out in Diver. One of the advantages it takes is those external definitions. We took them in, we calculated them internally, and so we may get the result from a payer group 6 or 9 months later, but we have it right now. And we have it for yesterday, we have it for last week, we have it for last month. I mean, we can do whatever we want with it. So, that real time, we meet with the physicians. It's in, we can show them, this is what your performance was, this last week. And that changes everything because that is actionable. We've also been able to create these that we drill down in all the way from in aggregate, how are we doing at the entity level, all the way down to the patient level. And so for those that are doing performance improvement, if you say, well, you had 2 surgical site infections, the next question is, well, who are the 2 patients? I want to go look them up. And right there, it's one click away. These are the 2 patients. They can go right into Epic and get all the details and figure out what happened there and whether that was preventable. That turnaround time, that PI part, that they can bring this data into meetings, they can look at it, use it, respond to it. All of that is just a world better in terms of that efficiency relative to that, very retrospective, dated, static report that we would otherwise get. And as I mentioned, that adjacency standpoint, this view is sitting right next to, the other tabs of our internal quality reporting, inside that quality module that I'd mentioned to you. So that's one example of how we're monitoring our progress in our performance in programs. It's also hitting our operational side. So, one of the areas that we needed to, in this new space around value, is engage with patients longitudinally. It used to be, you went into a hospitalization, you got discharged, that was the end of the hospital's job, and your primary care would pick it up or your specialist. Now, how do we actually tie this all together? We created a program called Penn Connects that we launched about 1.5 years ago. When you leave either a hospital setting or a procedure or the ED, we reach out electronically through text and voice responses to patients, and they ask a series of questions. And if any of those questions are alerts in a way that the response is negative, a centralized nurse team calls them up. We had done this before in sort of a informal way where you would have varying, different departments and different hospitals and different practices calling up. This is now uniform. It happens on every patient. It happens 7 days a week. They'll call up. The average response time for those nurses calling back the patient is under an hour. And so if they say, listen, I'm not feeling as good as I did a week ago, that'll trigger it, and it'll kick right into what's going on, what's your issue? Now we're leveraging our clinical expertise to say, is that a minor thing, no big deal, or is that a patient who, if we didn't reach out and if that contact didn't happen, 2 days later they would show up in the ED with something that would then have to be a readmission. And so we're definitely focused on how do we just get those light touches, but in a way that once there's an issue, we're able to quickly escalate and capture what would otherwise be patients coming back into the ED and into the hospital. So what are we trying to drive here from the patient side? Definitely targeting readmissions and that improved patient experience, that we're still with you even though you've left our hospital. You've gone home, but that doesn't mean you're not a Penn Medicine patient. And you may have a visit with your specialist, 14, 17 days after the hospitalization, but we want to make sure that, in between that time, you have an avenue to quickly alert if there's some issue. From our side, we're definitely looking, we have, our nurses are our vital resource, and there's a limited supply of them. We need to make sure that they're engaging with the patients that are needed. And so when we send out a questionnaire and the patient says, nope, I'm good, this is all working great, I just had a knee replacement, I'm doing wonderful. We spent, 20 cents because we sent them just a text, and they just said, nope, I don't need it, everything's going well. And, they'll still go up for their follow-up visit, but they don't need any engagement in the meantime. So what have we done on the analytics side around this? So we did build a Penn Connects dashboard. One thing we had to do was bring all the program data, all that call data into Diver, and that has gone very smoothly. In fact, we're getting to the point now where, like, anytime we have a program, it's like, oh, we need to bring in some external data. No, it's not an issue. We've been able to work through that, and I'm sure the analysts have to do all the work, and that is much heavier, but I'm amazed at how easy it's been to actually get that data to show up in there. When we asked the team, what are the outcomes you want to measure, you can see on the list here, hopefully it's readable, some of the things they thought that might improve, whether it's readmissions, mortality, we measure our Press-Ganey patient satisfaction scores. We had all of those already in there. The only things we didn't have was return back to the ED that came up. It's like, okay, well, we can add that in. And so bringing in, when they mentioned 15 metrics and 13 are already sitting in Diver, we're just going to pull them right in and match them up against the call data. That is the win here, which is we're not reinventing it. They don't even get to decide what they say. We want, readmissions. The readmissions is already defined there. We just pull it right in, and it's quick. And that is evidence of the win, because it's just so much quicker. And it's the same data that if they look on the other tab on all readmissions, it's the same piece, and now they're just looking at it within a program. Again, leveraging all that defined outcomes, you can go from the entity level, you can drill all the way down to a unit level. Turns out, we're getting a lot of calls back from this one set of patients that came out of this unit. Maybe that discharge team is not informing them, going through their after visit summary, going through their discharge plan of care, and making it clear. And there's real opportunities there to do better. And so now we're sort of shifting that and working on the front end of this, which is really where we wanted to get to. And then just overall, when we look at it, I mentioned in some cases we're doing one call. In some cases, we may call a patient 4 or 5 times in that 30 days. It could be, we're now getting program data back in our analytics that's showing, maybe, if that 5th call isn't needed, 4 calls is plenty. And again, we're all around this efficiency side. So this is really helping us get to where we want to be here. The last thing I'm going to show is a little related, and in the introduction we mentioned U.S. News. Before I get there, one thing I do want to highlight an outcome here. So in one of our hospitals already, this program has led to an 8% decline in readmissions, which is about 350 readmissions in a year. That is, that's significant, and the team is super excited about this work. So I mentioned this U.S. News and external benchmarking. The last piece I'm going to show, one of the areas that has a lot of similar issues around when you look at our value programs. We have external benchmarking and rankings. Again, these are external measures that are developed, and we need to understand how we do well in them, and why are they important? What we do is complex, and so anytime you have a measure out there that says these places do it well, it's important to acknowledge that, and so it is used as a proxy for quality for patients that otherwise can't, trying to decide where to go for surgery. It also is publicly available, so around brand and reputation, and also recruiting other physicians. That people want to be at places that are that have signals of high quality care being delivered there. And so, these challenges are the same a lot of times in these rankings. It is external metrics that are, in some cases, multiple years of data late. In some cases, 4 or 5 years old data is being used in some of these calculations because that's what's available. And so that becomes very difficult to have conversations with our physicians around how do you actually perform better in these programs. And so we developed a U.S. News and World Report dashboard. And so it turns out that U.S. News doesn't, rate you overall. They actually have a set of specialties that you rated individually, and so we're able in real time to put patients into the one of these 11 data-driven specialties or 20 procedures and conditions, and it turns out like it's Medicare fee-for-service only, so we have all the restrictions on the front end that what you're looking at in here are your U.S. News population, which is a subset of all the patients. And it's important when you go to a physician to say, we're going to talk to you, but we're only talking to you about 30% of your patients. It's like, well, how am I supposed to internalize that? Well, you can, because there's a dashboard there that shows you what it looks like. And so that brings it to life. A lot of times they'll say, U.S. News will use a definition that says these patients belong in this category, a geriatrics category. Well, we don't have a geriatrics, service line definition. Turns out that's a heart failure patient. We count it as heart failure. So we're able to apply our definitions on top of this data so that the heart failure team is looking at that patient, even though U.S. News is classifying it in their geriatrics group as an example. And so it enables us to use the way we're organized to actually improve our performance. And then just being able to track this over time. I mean, this is going again from that data that is 2 years old to something that is, current. All the patients that are being flagged are in there right now or in there last month. And just really helps with improving our performance overall. So those are a number of examples of areas that we are excited about and are all being built out in Diver and just being very flexible in that build. So as we look ahead, I think the last 4 years has been tremendous in our partnership with Dimensional Insight. We have, as you saw, rolled out 177 dashboards, all organized and operationally led and developed. As we do look ahead, I think from at least the healthcare side, I think there's going to be this a continued need to want to build out new definitions and new metrics and new dashboards because of, I think, in part, that changing landscape that we are in. And it's a long, it's not going to happen tomorrow, but it is a process, and we are knee deep in that. And so the way in which you can build that out, but still have one-stop shopping for your providers and for your leadership is, I think, the challenge that we are trying to overcome as we continue to build this out. But we look at what we've done to date. There hasn't been, anytime we reached out to the DI team and said, listen, this is a new dashboard we want to build. Every time it's been, okay, we can integrate that data. We can merge it in with what you have in there already. It's a very flexible platform that has proven to be, really powerful for what we're trying to accomplish within our analytics. So happy to take, I don't know I know we're trying to caught up on time, but happy to, questions or not if we don't have time.
Yeah, thank you, Greg. Thank you very much. We have time for 2 questions. First one.
Yeah. So one of the questions was we had on one of the slides an adverse event rate. That was an example of an external metric that was calculated by one of the payers that we brought in, but it ends up being a list of like 3,000 ICD-10 codes that any of those happen, they count as something that shouldn't happen and therefore is an adverse event count.